Sir, I welcome you on the behalf of entire MSN team that includes Mr. Ashish Gupta, he is our Senior Vice President, Mr. Tanmay Mandal, he is our Senior Marketing Manager, Mr. Nitin Chaturvedi, sir, he is our National Sales Manager, and Mr. Sushant Kumar Jena, sir, he is our Senior GM, sir. Sir, resonates a sense of purpose in the evolution of existence of human life. The creative capacity of a human mind has always been the source of inspiration. We believe every life matters and everyone deserves the quality medicines. Apart from the efficacy, affordability, and accessibility, we want to be the first to touch the impact of human lives. We are at MSN. Sir, we have got a global presence portfolio. We have got Asia's largest pharmaceutical research center. We have got 1,400 team of dedicated scientists. There are more than 17 plus world first branded generics we have already launched. We have got 42 scientific labs and 2 pilot plants, making it Asia's largest R&D center. We have got 690 plus patents for API and formulation innovations. Sir, at MSN, we have global quality manufacturing units also, that advanced global approved manufacturing site, that is 11 manufacturing plants in India and 1 manufacturing plant at USA. We have 30 plus approval from leading authorities of world, including US FDA, UK, MHRA, WHO, and many more. Sir, we have got 300 plus bioequivalent formulations and 450 plus APIs manufactured globally, sir. We have got the global presence also, that makes us the truly indigenous, having the global reach. We have got 65 plus countries, our presence is already there, sir. And we have got 410 global leaders in active US DMF filings, 10 global offices in US, UK, Colombia, Kenya, Uzbekistan, Kazakhstan, Peru, and Chile, and Mexico. And we have got more than 2,000 dossiers files globally. Sir, we have our cardiological innovations, which is the bridging therapy gaps that makes the world's first branded generics. In pulmonary hypertension, sir, we have introduced our Pulmonex and Pulmonex State. We have got Ryoshi, Mesitent, and Celipac. Our presence is also there in the anti-diabetic market with the Depavan, Empavan, and we have already launched Lina Next. Especially in hyponatremia management, we have got Tolvet, and anti-hypertensives, we have got our Azulera. And especially in the market of antiplatelet, we have Prasusef, TRA, and our Canreal. We are also having the future research portfolio. We are consistently innovating and evolving to create the robust products for diverse market across the globe. Especially in the heart failure, we are going to launch very shortly ferric carboxymaltose, and especially in anti-diabetic, we are going to launch sitagliptin and metformin hydrochloride combinations. Sir, is to partner in creating awareness in management of pulmonary arterial hypertension, approach for emerging treatment options that to increase the patient's life expectancy and quality of life. We are having our eminent speakers, Dr. Neeraj Avasthi, sir. A very small introduction about sir. Dr. Neeraj Avasthi, sir, is working as a senior consultant, Max Super Respiratory Hospital, Saket. Sir has got the best fellowship in the Pediatric Cardiology National Board at Scott's Heart Institute and Research Center, Delhi. Sir has expert in pediatric cardiac interventions, pediatric PH and cardiomyopathy, fetal echocardiography, pediatric cardiac imaging. Sir has got more than 100 research papers published in various national and international journals and author for many textbooks. Sir is an active member in MCI, DMC, American Academy of Cardiography, and Cardiac Society of India. Our second speaker is a very eminent speaker is Dr. Vivek Nangia, sir. Sir is working as Principal Director in the Head Institute of Respiratory, Critical Care and Sleep Medicine, Max Hospital, Saket, Delhi. Sir is a luminary and pioneer in various bronchoscopic interventions in medical thoracoscopy in Delhi. Sir has served as a head and director of 3 most renowned hospitals, including the Batra Hospital and Medical Research Center, Fortis Ranjandhal Hospital, and Max Hospitals, Delhi. Sir has been facilitated with some of the most coveted awards, like Award of Excellence from his alma mater, Modern School, Barakhamba Road, New Delhi 2021, and Asia GCC Iconic Health Leader Award for Excellence and Leadership. Best Pulmonology Award in this NAPCON 2022. So, sir, we are already in the process of launching our first oral prostacyclin receptor agonist to delay the progression of PH Group 1. We have launched Celipac 200 microgram and 400 microgram. The trusted partner in every stage of PH. With this, I would like to welcome, sir, our first speaker, Dr. Neeraj Avasthi, sir, to start his presentation, sir. Neeraj Avasthi, sir.
Thank you, Vineet. Thank you for the wonderful introduction. Am I audible?
Yes, sir.
Okay. Thank you, Vineet, for the wonderful introduction. And at the outset, I would like to thank MSN for giving this opportunity to interact on such an important topic, that is pulmonary artery hypertension. Now, pulmonary artery hypertension is something which is always considered a rare disease classically, but we must understand that it is not so rare. It is a rarely diagnosed disease, I would say. It is actually a tip of the iceberg which we see in our tertiary care centers, and most of the diseases manifesting as asthma, manifesting as cardiac manifestations, would have underlying a pulmonary artery hypertension, which is either occult, which is getting missed, and it is up to all the physicians who to have an open eye for pulmonary artery hypertension. I would today focus on pulmonary artery hypertension in congenital heart diseases. Congenital heart diseases, well, it's a non-specific term and includes a range of defects right from birth, which affect the normal physiology of the heart and the circulatory system. They are essentially because of multifactorial. There's no specific cause to it, but they are known to arise from genetic, environmental causes, and the prevalence is almost 1% of the live birth. That means every 9 in 1,000 babies in UK. And as per the study from All India Institute by Dr. Anita Saxena, it was in India, the prevalence is almost 8 per 1,000. So world over, it is around 8 to 9 per 1,000. So many of the babies who are actually born with congenital heart diseases. This is just to show the congenital heart disease and the status report that naturally, more the birth rate, more is it likelihood of a congenital heart disease. But why? Why this congenital heart disease? Well, we know it is broadly divided into a cyanotic heart disease or a cyanotic heart disease. Cyanotic heart disease, where the patient is essentially blue, and in most of the cases, these patients are reasonably preserved and they do not have pulmonary artery hypertension. But remember, rest of all the spectrum of congenital heart diseases, be it a transposition physiology, that means the child is blue but is having a pulmonary artery hypertension, be it a shunt, any of the shunt lesions, VSD, PDA, ASDs, AP windows, or any of the obstructive lesions, all of them are likely to have pulmonary hypertension. Now, what is the difference between pulmonary artery hypertension and pulmonary venous hypertension? That means pulmonary left-sided heart lesions may lead to pulmonary venous hypertension, such as coarctations, such as LV dysfunctions, such as aortic stenosis leading to high LVDPs, leading to secondary pulmonary hypertension, and rest of them would lead to pulmonary hypertension. In pulmonary hypertension, if congenital heart disease is left uncorrected, so minus a tetralogy physiology, that means every congenital heart disease is a predisposition factor for congenital heart disease. So this review in European Respiratory, one of the journals which was published, clearly shows that in patients with uncorrected left to right shunt, because of the progressive modeling, the PVRI is likely to increase over a period of time. And what are the diseases which are more likely to progress? Evident from this particular chart, where both the pressure and the volume overload is on the vent. Whenever there is a shunt lesion, that means left and the right heart are in communication to each other. It is causing pressure overload of the heart, because pressure from the high left side is getting transmitted to the right side of the heart. It is also leading to the volume, the blood, extra blood, which is going to the right side of the heart. So there is a pressure overload and there is a volume overload. This pressure and volume overload is maximal as you go away from the aortic valve. That means AP windows, which are huge communications generally, are likely to progress very fast. Similarly, AV canal defects, large communication at both atrial and the ventricular levels, they are likely to progress very fast. So these are some of the diseases which are likely to progress very fast to isomigraization to severe irreversible pulmonary artery hypertension. So if we have to talk of congenital heart diseases, isolated, well, we all know of classification of pulmonary artery hypertension. We know they have been classified into groups, and we know that there is a specific group of left side heart diseases which needs to be ruled out for all those. Minus those, how do you classify a pulmonary hypertension in congenital heart disease? One is Eisenmenger. Eisenmenger syndromes include all systemic to pulmonary artery defects, which lead to such increased pulmonary vascular resistance that instead of left to right shunt, the shunt becomes right to left. That means the patient begins to get blue. The patient not only begins to get blue, the blue blood which is going into the circulation will stimulate erythrocytosis and multiple organ involvements. So this is a classical Eisenmenger syndrome, very commonly seen in large shunt lesions such as ASDs, VSDs, PDAs, Eisenmenger syndrome, and very late presentation. Group B is in patients there is an increased PVR which is mild to moderate. That means these patients are still operable. It is this subgroup of patients which we need to catch in congenital heart disease. If you have a patient with a severe pulmonary artery hypertension, try to identify patients where still we can catch in group B. We can still treat and operate. With small defects, of course, most of them will not need treatment or will be operable. Or there will be one group of patients, even if the surgery has been done, they will require some amount of therapy even after therapy. So this is just to, with a cartoon, trying to show various sides of pulmonary artery hypertension. But remember, how do you approach a patient with a congenital heart disease? Most importantly, suspect any patient who is having Lewis disc abrasion is likely to have a reversal of shunt. Always look at the feet of the patient. It is possible that the hands of the patient may not be blue, such as in large PDAs, but the feet of the patient are blue. And one keeps on treating as pulmonary artery hypertension, while it's actually a shunt lesion, which is the cause. Always examine the femoral arteries. Distal obstruction may actually be a very good factor for the patient to become operable, even if it is diagnosed as Eisenmenger syndrome. To collaborate, an X-ray may be a very, very good evidence. The central pulmonary arteries, if they are dilated, lungs which are black, they tell you that this patient is less likely to be operable. On the other hand, except for ASDs, if there is a significant cardiomegaly, this is one factor which tells you, yes, this patient may be operable. Remember, if there is a murmur in the patient of Eisenmenger syndrome, there is a possibility that this patient may be operable. Ejection systolic murmur means there is a gradient between the left ventricle and between the ventricle and the lungs of the patient. So there is an antegrade flow which is there. And if there's an antegrade flow, the pulmonary artery pressures are likely to be softer. So presence of murmur will tell you that probably this patient may be operable. Yes, there will be appearance of murmur of TR and in a very late in the disease where patient may not be operable. But in most of the cases, if there is an ejection systolic murmur, most of the time, these patients are operable. You get an X-ray done and you find a cardiomegaly and a large heart. This patient may still be operable and may not be Eisenmenger. So as a physician, we should always endeavor to pick up how we can diagnose an operability in any patient of congenital heart disease, any patient of pulmonary artery hypertension. Say a echocardiographic report comes to you and you find it's a pulmonary artery hypertension. Auscultate the patient. Murmur, this patient may have some disease which may be operable. X-ray showing cardiomegaly, this patient may be operable and there may be evidence that this patient is still operable. You auscultate the back and the chest and you find a continuous murmur, you have clinched the diagnosis. This patient is definitely operable. If there is a murmur in the chest of a severe so-called Eisenmenger patient, labeled Eisenmenger patient, this patient is not Eisenmenger. This is an operable patient. This may be a peripheral pulmonary stenosis. So most important diagnosis comes not from the echocardiography. The most important cardiographic findings come from good clinical examination and a chest X-ray. Well, echocardiography will tell you the intracardiac anatomy, right to left shunts, chamber dilatations, TR velocity, which may indicate what the PA pressures are. MRI may collaborate with it. As a rule, if there is a severe pulmonary artery hypertension patient, we get a CT pulmonary angio done for every patient. Why so? One, to look at the cause. Many of them can have a treatable cause in the form of CTPH. That means chronic thromboembolic pulmonary hypertension. Maybe some clot is sitting in the periphery, which we pick it up and we treat it, and we can actually treat the cause. So this is very important that we look at the underlying cause of pulmonary artery hypertension, and CT may give a very, very important clues. Peripheral stenosis. And nowadays, most importantly, we presented a series recently of pulmonary artery hypertension patients which were Eisenmenger's, but which were actually not Eisenmenger syndromes. And of these, we have around 250 patients of PH registered in a clinic. And of this, 35 patients were labeled Eisenmenger's, which were not Eisenmenger's, and they had a treatable cause. And one of the most important treatable cause of pulmonary artery hypertension is Abernethy malformation. That means a communication in the liver between the systemic vein and the portal vein. Porto-systemic communication anywhere in the body falsely lead to pulmonary artery hypertension pressures being high. You treat it and you have treated the cause, and the patient becomes absolutely normal. About right height catheterization. Right height catheterization is relatively safe modality. It is not that risky as it is propagated. It is most of the time it's a daycare job. You just pass in a catheter, take the withdrawal gradient across it. Advantage, you can tailor your therapy. You know how much pulmonary artery pressures you are really dealing with. You know if the patient is vasoreactive. We had many patients who were vasoreactive, and instead of giving so many drugs, just a simple calcium channel blocker will treat them with beautiful response from pulmonary artery hypertension. So a vasoreactive testing and a cardiac catheterization is a very good modality to initiate the therapy of pulmonary artery hypertension. Coming to the topic for the day, Selexipag. Selexipag treatment for pulmonary artery hypertension with congenital heart disease. I would take the example of a very important study, which was a Griffon study. And of it's a study which any person who is dealing with the pulmonary artery hypertension should actually go through. They had a good number of patients, almost over 1,000 patients. But of these, 110 patients were diagnosed with congenital heart and pulmonary artery hypertension. 55 of them having an ASDs, 38 having other defects, 14 having PDAs, and 3 had non-specific defects. And they received 1:1 Selexipag, and almost all of them received some amount of underlying drug therapy. That means they were already on either endothelin receptor blockers or they were on PDE5 inhibitors, and they received a 200 microgram of therapy. And once they received the therapy, they had a beautiful response which was shown, and this can be elaborated here. Most of them were in group 2 or 3. A 6-minute walk test had greatly actually shown a benefit. And as for the composite endpoint of morbidity in PAH, one would say that if you look at this graph, definitely those receiving Selexipag had almost a 20-year benefit over 20% benefit over 30 years in most of these patients. The patients, as for the side effects, Selexipag is a relatively innocent medicine. Most of the time, we have seen side effects with our little experience over last few months. When Selexipag was brought in by MSN, we have given it to a few of our patients. We would say that most of the time, it is initial headache and a myalgia which is there, which is essentially related to first few doses. Personally, I feel it is because of the systemic vasodilatation. And most of the time, we give an advice to our patients that once you take a medicine initially, just lie down and raise your legs a bit, so that after a few doses, this settles. This was seen similarly for bosentan and ambrisentan also initially. And nowadays, we realize that if we give the same therapy for our Selexipag, this will benefit. And this is mostly with initial doses. Headache, myalgia, diarrhea, jaw pain is something, yes, which has been reported for selectively for selexipag. Personally, I have not come across a patient who had a jaw pain in our limited series, but the series definitely reported almost 2 patients of 225 adverse effects, which is actually minuscule. They have a peripheral edema, arthralgia, flushing, vomiting, which has been described. Now, what this Griffon actually concluded is, in CHD patients, the treatment effect of selexipag on primary composite endpoint of mortality and morbidity was consistent with the overall population. And selexipag was relatively well tolerated. Selexipag was, and this is a very important point, may delay disease progression and is very well tolerated in congenital heart disease and PH patients. That means it's a very good add-on therapy. Suppose your patient is on bosentan and sildenafil, which is the commonest, both the target which we are already focusing. There is a very good on third pathway which can be targeted in the form of selexipag. Well, for a wide range of adult, it is a proven therapy. This is another publication which shows that in a 5 expert centers from 2017 to 2019, a total of 34 patients were included, and these included 21 Eisenmengers, 2 systemic to pulmonary artery shunts, and 11 patients after correction of defects, and majority of them tolerated a dose quite well, and dose of around 400, which is 400 microgram, which was given to them. That means 2 tablets per day of 200 microgram. Yes, and as we come to the individual characteristics, there you see that of the 34 patients, the Eisenmengers, which we already discussed, these are a subgroup of patients, and there was definitely a 6-minute walk test, which was when most of them are in group 2 or 3. So most of the patients in this particular selexipag are optimized when they are given for group 2 and 3. Event-free survival was significantly worse for patients with Eisenmengers as compared to those with PH after defect correction. But this is on a very selective group of patients. The defect correction has to be offered definitely after cardiac catheterization. And after cardiac catheterization, if they are suitable, then only a defect correction. What does it mean? It means either you start the therapy, then go for defect correction, you recatheterize the patient, and then continue the therapy. That is the best way. The other is a few centers, which I am not a very proponent of the same, is you treat the defect, continue with the medicines, and then you see how it happens, as is for this particular study. Remember, idiopathic PH, that means a pulmonary artery hypertension with intact septum is worse off than a pulmonary artery hypertension with a CHD. So always it is a good idea to treat, then cure, and then treat, rather than treat and then cure. This is something which actually I'll jump, which we have discussed. The study concluded that patients with PH after correction may have better tolerability and better clinical benefit from selexipag than patients with Eisenmenger syndrome. Now, coming to contemporary use of selexipag in pulmonary artery hypertension with congenital heart disease, remember, most of these have been case series. This is actually a 5-case series which was published, and each case is a different case in itself and probably talks in length of how we are going to do with this CHD group. First 2 cases was as the initiate part of treat to close. That means they treated with selexipag and then closed the defect. In third patient, it was Eisenmenger's patient. So they actually initiated selexipag and see how Eisenmenger is behaving. In 4th and 5th cases, there was a rapid cross titration protocols. That means they transit from prostacyclin to selexipag. And in 4th cases, selexipag was initiated in the context of side effects. So prostacyclin has side effects, so they initiated selexipag. And in 5th cases, they down titrated it after treatment of the congenital heart defect. And what was the observation? And mind it, this is a very good paper because it talks of how selexipag, and it is actually a representative of this group of patients. Either we will have patients who have, say, ASD and Eisenmenger physiology. You are going to initiate the therapy, and this patient continues to be on selexipag. He is going to benefit hemodynamic suitable closure of atrial, improved symptoms. So a 6-minute walk test is going to improve over a period of time. And actually, this ASD patient was made suitable enough to actually treat it. So it was a Eisenmenger physiology, but not actually an Eisenmenger. And for a AP window, it continued to be on treatment. And remember, all of them are in WHO group 2 or 3. All of them which have actually benefited, mind it, are between in group 2 and 3. And all of them has been on some underlying therapy, such as mezanintan, tadalafil, or selexipag. So I will not go into initial causes, but I will come to a very important aspect, which is infants and children receiving. Now the question comes, what about children? All the studies which we have discussed have been more than 18 years of age. Definitely all of them have been more than 18 years of age. But what about children? As for children, there have been case reports. I have taken this particular study from Journal of Heart and Lung Transplant, and this talks of 9 children which have been given selexipag therapy, and they have shown a beautiful benefit. Dosages, the dosages I would say is whenever, and they are all more than 2 years of age. So 2 to 18 years of age, there have been multiple case reports where therapy can be tried. From 2 years to from 2 years to 10 years, the dose is actually 50 to 100. From 10 years to 18 years, the dose has been from 100 to 200, and beyond that, we start from 200 and titrate the dose upwards. Similarly, multiple studies which have demonstrated. But if we talk of a real trial, that means treatment of pediatric patients with pulmonary artery hypertension, the Janssen has initiated a phase 2 trial, which is likely to complete it in 2028, where they are giving UPTRAV, that means selexipag for this group of patients, and we are awaiting their results for less than 18 years of age, from 2 to 18 years of age. But underlying, many case reports have demonstrated the utility of selexipag beyond 2 years of age also. So, summarizing the practical aspect of selexipag, most of our patients had a manageable side effects with selexipag. Most of the patients include headaches, myalgias, arthralgias, fatigue, nausea, vomiting, diarrhea, jaw pain, dizziness, flushing. But these are very minuscule side effects, and I would say headache is the only side effect which we have practically observed in our subgroup of patients, or these are the reports which have been published. Side effects only warrant discontinuation in 8% of the patients in the published series. So most of them tolerate the side effects very well. From Griffon study, it is emphasized that the individualized maximal tolerated dose of selexipag on the primary composite endpoint was consistent across low, medium, high doses of selexipag. That means from a Griffon study, one can easily titrate the dose as per the patient, and one can start from 200 and go up to 1600 or 1800. And the potential explanation for the similar clinical benefit with varying doses is that the density of the prostaglandin receptors may vary among the patients. The receptors may actually decrease in size, numbers, or increase in numbers, and there have been many studies to talk about this. And this could actually explain that various doses working in various patients. The future directions, one has to identify clinical predictors of patients which are likely to have suitable hemodynamics for closure of oral triple therapy, may guide our use of selexipag and parenteral therapies in treat to close therapy, treat to close strategy. That means we initiate a therapy, we follow up this patient, and maybe subsequently we might be able to close this defect subsequently. Like, say, if there is a patient of atrial septal defect, this patient is on bosentan, sildenafil, and you feel this patient has a good cardiac cath parameters, but still the basal parameters are not great. The step up is not great, and PVRI is more than 4. It will be a good idea to initiate an add-on selexipag therapy, recatheterize and reassess the patient of 3 months and 6 months, and see if you can close this and continue the therapy with selexipag. Say close this defect with a ASD patch and leave a residual ASD, or close with a device and leave a residual ASD, and continue your therapy with the selexipag and add-on therapies. Initiating oral triple therapy may be initial strategy for PH-CHD if studies investigating the strategy upon patients with WHO functional class 2 or 3 can identify the renal pathway. That means instead of initiating with one therapy and then monotherapy, then going to dual therapy, then shifting to triple therapy, why not initiate with all the 3 pathways upfront, so that our patient gets the benefit of all the 3 pathways, and then we can always consider either de-escalating the therapy, or if the patient has side effects, or considering treat to close therapy. Well, future studies on specific subgroups of CHDs may be important, such as looking at ASDs, looking at VSDs, looking at AP windows, looking at TGAs, and of course, understanding the factors that influence individualized maximum dose could help us uptitration strategies and minimal interruptions, so that we know why these changes are happening. As of now, we are just contemplating. We really don't have a reason why a patient responds to just 400 microgram, while another patient may not respond and may need a very, very high dose. Highlighting, I would say the CHD is one of the most common underlying defects of pulmonary artery hypertension. Evidence supporting the use of pH therapies in patients with corrected pH has started to emerge. The oral route of administration of selexipag overcomes many of the challenges of parenteral prostaglandin therapies and is thus a very good oral therapies. As of now, we had no oral prostacyclin therapy available, and selexipag is definitely a boon, and which is giving another pathway for us to act on. Patients at various stages of the spectrum of pH with CHDs can benefit from this particular therapy, and titration of selexipag should focus on achieving individualized maximum doses for each patient. That means maximum doses at which you are able to improve the quality of life, or a 6-minute walk would be warranted in any of these patients. I think I'd like to end here and thank you all for patient listening. I'll hand over to Vineet for the midfield. Vineet, you're not audible.
Yeah, sir. Thank you, Dr. Sir. Thank you so much, sir, for an excellent talk, sir. With this, I will request Dr. Vivek Nangia, sir, to start his talk, sir. Dr. Nangia, sir, please.
Yeah, thank you, Vineet.
Thanks, sir.
Just give me a minute. Okay, Gia, ready to go now.
Vineet, there are a few questions we are taking towards the end, right?
Sir, yes, sir.
Okay, good evening, everybody, and it's indeed a proud privilege for me to be here on this platform today discussing with you about pulmonary hypertension, especially in chronic lung diseases. Well, this is always a very debatable topic, whether there is any benefit of using any medication for such patients or not, and that is what I'm going to allude on today in the next 20-25 minutes. Basically, there's been a revision in the definition of pulmonary hypertension, which earlier was supposed to be considered if the mean pulmonary artery pressure was more than 25 at rest, has now been downgraded to a mean pulmonary artery pressure of more than 20 at rest and more than 30 on exercise. And this could happen as an isolated entity, like what we label it as idiopathic pulmonary hypertension, arterial hypertension, or it could also happen due to an underlying cause, like a left heart disease or a lung disease, hypoxia, or a arterial obstruction like CTEPH, sarcomas, angiosarcomas, so on and so forth. So there can be various causes which could be resulting, based on which we have this clinical classification of pulmonary hypertension, which we are well aware of and have been reading since quite a long time now. But the focus of this evening is on the pulmonary hypertension due to lung diseases. The main lung diseases that we encounter in our day-to-day practice are obstructive lung disease, that is the chronic obstructive pulmonary disease, COPD, COAD, or a restrictive lung disease, that is the ILDs, IPFs, IIPs, and there's this huge list of interstitial lung diseases that can actually result in pulmonary hypertension. Then there are other lung diseases with mixed restrictive and obstructive pattern like sarcoidosis, etc. Then there could be hypoxia without lung diseases. For example, obstructive sleep apnea or obesity hypoventilation syndrome, or patients on high altitudes, and then subsequently developmental lung disorders. So this is what we're going to be focusing on today, these 4 or 5 entities. Now, when we look at the hemodynamic classification, as I said, the levels for mean pulmonary artery pressure have been lowered to 20 mm now. So even COPD, if it is without pulmonary hypertension, then the mean PAP should be less than 21. Or if the PAP is between 21 to 24, then the pulmonary vascular resistance should be less than 3 Wood unit. If it is with pulmonary hypertension, then the mean pulmonary artery pressure has to be between 21 to 24, and with a pulmonary vascular resistance of more than 3 Wood units, or a mean pulmonary artery pressure of more than 25 to 34 millimeters of mercury. And then it is labeled as severe pulmonary hypertension if the PAP is more than 35 or more than 25 with a cardiac index of less than 2. Now, if you look at the various entities in which you can encounter pulmonary hypertension, COPD seems to be one of the commonest ones. And of course, IPF and IIPs also have a very high range. They have a very high prevalence of developing pulmonary hypertension, probably 8 to 45%, depending on the severity. The mean pulmonary artery pressure of more than 40, however, is relatively uncommon, occurring in almost about 10% of IPF patients only. Whereas in COPD patients, the mean pulmonary artery pressure of 20 millimeters is seen in about 3% of the patients, and 3% have mean pulmonary artery pressure of 40 or more. So when we look at a figure of 35 or 40, this is considered to be disproportionate to the underlying lung disease, unless the underlying lung disease is also very, very severe. Yet to have a PAP of more than 40 is slightly uncommon or rare, I would say. So that is where you need to explore other causes that why this could be happening. Maybe there's an underlying pulmonary embolism. When we look at the sleep-related breathing disorders, it could be an underlying, OSA is rare to cause pulmonary hypertension, while obesity hypoventilation is quite commonly resulting in elevated pulmonary artery pressures. So as I was saying, that there could actually be a pulmonary hypertension, a mild pulmonary hypertension resulting from COPD, severe COPD resulting in pulmonary hypertension, but at the same time, there's also a possibility that if the pulmonary pressures are really very high, you may want to consider the possibility of a PAH coexisting. That means pulmonary artery hypertension coexisting, or an idiopathic pulmonary arterial hypertension coexisting. So as I said, that up till 35 is commonly seen, but above 35 millimeters mercury of mean pulmonary artery pressures, you need to start thinking that is there some other cause that could be causing it, resulting in it. The main reason for developing pulmonary hypertension is the remodeling of the pulmonary vessels. There's an enlargement of the intimal layer in the muscular arteries, which is produced by the proliferation of smooth muscle cells. And in the arterioles, there is development of a medial coat of circular smooth muscle bounded by a new elastic lamina. Smoking induces remodeling of pulmonary artery, which could further enhance the chronic hypoxia. And there could be some degree of endothelial dysfunction also that could be seen in these patients. This is associated with an impaired release of endothelium-derived vasodilating agents and increased expression of growth factors. There's a graphical representation of the same, where the first is the picture of somebody with a control subject without COPD. This is basically a pulmonary artery with a moderately remodeled intima in a patient with COPD and mild pulmonary hypertension. Then you have this third picture where it is pulmonary muscular artery with a highly enlarged intima from a patient with COPD, with severe pulmonary hypertension. And then you have fourth picture showing a prominent muscular hypertrophy in a patient with pulmonary arterial hypertension. Now, besides remodeling, there are various other causes also that could result in increased pulmonary vascular resistance in COPD patients. First of all is airflow limitation, where there could be consequences resulting in pressure swings, then emphysema resulting in reduction of the vascular bed, alveolar hypoxia due to vasoconstriction and remodeling, of course. There could be a hypercapnic acidosis, which results in vasoconstriction again, polycythemia resulting in hyperviscosity, lung and systemic inflammation resulting in remodeling, including fibrosis. So in severe emphysema patient, the pulmonary vascular resistance weakly correlated with the DLCO, suggesting that in patients with markedly predominant emphysema, loss of pulmonary capillaries may play a role in the development of pulmonary hypertension. So what are the consequences of pulmonary hypertension in COPD? Well, it has been identified as an independent prognostic marker of COPD, indicating a poorer prognosis. There's an increased risk of COPD exacerbations, increased hospitalizations, and a worse survival. That is what we've also been seeing in our practice on the routine. Therefore, every patient of COPD at some point or the other must be evaluated for an underlying cor pulmonale or elevated pulmonary hypertension, pulmonary hypertension as you would call it. So it is important to rule out that there's no CTEPH underlying. You look at the left heart, sleep-related breathing disorders are ruled out. Then risk factors for PH have to be considered, like HIV, portal hypertension, and associated connective tissue disease. Detailed pulmonary function testing should be done. Imaging techniques have to be adapted to, like an HRCT or a cardiac MRI. Right heart catheterization continues to be the gold standard for determining the PA pressures. CPET or a cardiopulmonary exercise testing can be carried out. And then there's a marker circulating BNP. So let's look at it from another perspective, that first of all, a simple examination where, sometimes just examining the chest could give you Krebs, could give you wheeze, but that would not indicate the presence of pulmonary hypertension. The Krebs could be because of the underlying emphysema also. So peripheral edema is one marker that you could look at. NT-proBNP elevation in the absence of a left heart disease could indicate a presence of pulmonary hypertension resulting in failure. PFT is important to confirm the diagnosis of COPD. DLCO should be done in situations where the lung parenchyma is preserved. The existence of pulmonary hypertension may be associated with a decrease in diffusion capacity. And then, of course, the exercise testing, as I said, cardiopulmonary exercise testing could be performed where a diminished exercise capacity and greater impairment of gas exchange at rest or during exercise than that expected based on ventilatory limitations could indicate the presence of pulmonary hypertension. On a CECT thorax, you have to calculate the ratio of the main pulmonary artery to the ascending aorta diameter, and a ratio of more than 1 is suggestive of pulmonary hypertension in COPD patients. Then cardiac MRI can be done. Parameters of pulmonary artery stiffness, such as pulse wave velocity, have high sensitivity and specificity for identifying pH, and other parameters such as right ventricular mass index and pulmonary artery relative area change are useful in assessing the prognosis of COPD pulmonary hypertension. Echo is a simple, non-invasive, easily accessible tool, which is critical in the diagnosis of any patient with suspected pulmonary hypertension. It allows the evaluation of hypertrophy also, or the dilatation of the right ventricle and the estimation of systolic pulmonary artery pressures. Then you also have the right cardiac catheterization, which I said is the gold standard tool to confirm the diagnosis of pulmonary hypertension. Now, based on this, when you want to look for pulmonary hypertension, this is how you can classify all your patients. There would be the first category where there is COPD patients without pulmonary hypertension with a lesser risk of mortality due to pH. I mean, there would be no risk at all with mortality due to pH because there is no pH in these patients. So in these patients, you would get a FEV1, which is markedly diminished, DLCO, which could be normal or diminished depending on the lung parenchyma involvement. 6 minutes walk test or CPET may show a reduced activity. PO2 may be normal or reduced. But when you perform their pulmonary hemodynamics, then MPAP would be less than 20, or MPAP may be 21 to 24, and the PVR would be less than 3 Wood units. Then when you're dealing with a patient with COPD with post-capillary pulmonary hypertension, of course, the risk mortality is certainly higher, slightly higher, but this would actually mean that there's a left heart involvement in these patients. So FEV1 would be reduced depending on the severity of the illness. DLCO would be reduced, 6-minute walk test would be reduced, PO2 may or may not be reduced, but MPAP would be elevated with the arterial wedge pressure also being elevated to more than 15. Then there could be a situation where you have a proportionate mild to moderate pH proportionate to the underlying lung disease. Again, in this situation, there would be a moderate risk of mortality due to pulmonary hypertension. And in this situation, again, the FEV1 would be reduced, DLCO would be reduced, 6-minute walk test would be depending on the ventilatory limitation, PO2 may be mild to severely reduced, but the mean pulmonary artery pressures would be 21 to 24 or even higher for that matter, with a pulmonary vascular resistance of more than 3. So PVR would increase significantly. And then finally, you have the typical pulmonary vascular phenotype where the FEV1 is reduced, DLCO is significantly reduced, but FEV1, as you can see here, is disproportionately reduced to the elevation in the pressures. So the mean pulmonary artery pressures are significantly higher while the FEV1 is not as high. So this is what we are looking for, the pulmonary vascular phenotype in these patients of COPD who carry a much higher risk of mortality. So as a part of treatment of pulmonary hypertension in patients with COPD or ILD or any other respiratory disease, the first thing is to optimize the basic underlying pathologies treatment, and then supplement Auxin if the patient is getting hypoxic. Usage of Auxin for 15 hours per day in these patients prevents the progressive increase of PAP. When used for more than 18 hours per day, produces a slight decrease of PAP. However, it has little impact on pulmonary hemodynamics and does not reverse the pathological lesions of the pulmonary circulation. It does not provide benefit in terms of survival or hospitalizations. This algorithm, Dr. Neeraj also discussed with you that when you have a patient where you're suspecting pulmonary arterial hypertension, the first thing you do is check the vasoreactivity using adenosine or nitric oxide. And if it is vasoreactive, you would put the patient immediately on a calcium channel blocker like a diltiazem or something. And if it is non-vasoreactive, then that is where the entire Pandora's box opens up and you choose from one of these various agents that are available to us. If it is low to moderate risk, you could use a combination therapy or a monotherapy, where now we have Selexipag, which is being commonly used with very good results. So the three basic therapies, the three targeted pathways are one of the endothelin pathway, where you have the endothelin receptor antagonist, ambrisentan, bosentan, macitentan. Then you have the nitric oxide CGMP pathway, where you have the PDE5 inhibitors, riociguat, sildenafil, tadalafil. Actually, riociguat is an SGC stimulator. And then you have a prostacyclin pathway, where you have the beroprost, ipoprost, iloprost, treprostinil, and now Selexipag also. So any of these can be combined together and given, I mean, A, B, C, A plus B, A plus C, A, B plus C, A plus C, anything combination can be used in any of these patients. So their studies have shown that endothelial dysfunction plays an important role in the pathogenesis of pulmonary hypertension in COPD patients. However, data to support the use of PAH-specific therapies is very, very scanty and limited in this group of patients. In fact, a randomized study using bosentan actually showed that in patients of stage 3 or 4 without severe PH resulted in worsening hypoxemia. Another non-randomized study on bosentan showed significant functional improvement in those with COPD with stage GOLD 3 or 4. Of course, there's old studies. I'm talking about the older categorization of COPD patients. Then use of sildenafil and iloprost in the same type of patients resulted in hemodynamic improvement without any significant clinical benefit, but instead it worsened the hypoxia. Artemis trial had to be stopped early after patients in the ambrisentan group were more likely to have disease progression. And the RISE IIP trial, there was increased mortality and serious adverse events in the riociguat group. So we don't have any definite paper supporting it, while using the specific PAH therapies, yet the idea that the specific therapies may work does not go away from our minds. Selexipag is a good drug. It's an oral selective prostacyclin receptor agonist for the treatment of pulmonary hypertension. This is a multi-center phase 2 double-blind placebo-controlled trial with a 17 weeks duration, where they included all patients with PH with age more than 18 years, idiopathic or familial, CTD-related, corrected congenital, or anorexicogenic use-related PAH. 12 weeks of stable background therapy with PDE5 and plus minus one of those ERA agents had been going on, and baseline RHC showed pulmonary vascular resistance of more than 400 dynes and a 6 minutes walk test distance of 150 to 500 meters. This is one of the older studies. Now, at week 16, the pulmonary vascular resistance in the Selexipag group and the placebo group were quite different. In the Selexipag group was 80.7%, and in the placebo group, it was 115.9%. So they had actually worsened. So there was a statistically significant benefit with the use of Selexipag by nearly 30% in the treatment group. It was well tolerated, and it had a good safety profile in line with that of the expected pharmacological effects. So in this event-driven study involving patients with PAH, the risk of primary composite endpoint of death or complication related to PAH was lower amongst those who received Selexipag than the placebo. The treatment effect was driven by differences in disease progression and hospitalization, and the effect of Selexipag was consistent in all pre-specified patient subgroups, including those defined according to the cause of the pulmonary hypertension, disease severity, and baseline treatment. The addition of Selexipag to a baseline regime of 2 medications for pulmonary artery hypertension resulted in benefits that were consistent with the overall treatment effect. The dosage is 200 micrograms twice daily, which needs to be increased gradually at weekly intervals. So you start with 200 mcg BD and go up every week by 200 microgram twice a day till you reach a dose of 1600 microgram twice daily. In the presence of moderate hepatic impairment, you could increase it by 200 microgram every week till you reach the dose of 1600 micrograms total. This was a study of Selexipag in COPD patients with out of proportion pulmonary hypertension. So as I said, out of proportion would mean a resting MPAP of more than 35 in the presence of relatively preserved lung functions. These were patients, study of 6 patients who were on LTOT, and the mean age of these patients was 72. 67% of these were females, and they were all white. So of course, the study has a lot of limitations, starting from the fact that it only had a small number of patients. Yet I think it is quite a significant study. The BMI was 30.6. That means they were on the overweight obese side. 67% had OSA, 83% had hypertension, 67% had diabetes, 60% had underlying CAD. So there were other comorbidities also in these patients. 17% had pulmonary embolism also. 67% were smokers. The FEV1 was 60% and FVC was 71%, again indicating that the lung disease was not as bad to account for such high pulmonary artery pressure. So this is what is called out of proportion or disproportionate elevation in pulmonary artery pressures. So out of 6 patients included in the study, 5 patients showed an improvement in the 6 minutes walk distance from 512 feet to 681 feet with a mean change of 169 feet, while 1 patient only worsened from 1177 to 913 feet. Out of the 6 patients included in the study, 5 patients showed a decrease in MPAP from 50 millimeters to 38 millimeters with a mean change of 12 millimeters, again, which is very significant, while 1 patient worsened from 46 to only 47 millimeters in the pressures. So there was an improvement in 6 minutes walk test. There was improvement in the Bogue scale before 6 minutes walk test and after 6 minutes walk test. Heart rate improved after treatment. The Auxin saturation remained more or less similar. So there was no change in the Auxin parameters, which is not even expected. But definitely the MPAP reduced, the pulmonary vascular resistance reduced from 7.5 to 4.7. The PCWP was slightly increased, cardiac output improved, and cardiac index also improved with the use of selexipag in this group of patients. So this study actually concluded that in a case series of COPD patients with out of proportion pulmonary hypertension, the use of selexipag was associated with a trend towards improvement in patients' functional status assessed by the 6-minute walk test and reduction in MAP at 6 months. PVR also showed a significant decrease with the 2.8 Woods mean change. Cardiac output, cardiac index improvement was also noticed on the follow-up. Griffon trial has already been discussed by Dr. Neeraj. The trial was actually where ERA was given as monotherapy as well as a combination therapy. It was used in all group functional class, the 1, 2, 3, and 4, in males as well as females, in all age groups, less than 65, more than 65, on all the various indications where it could have been used, and a wide range of geographical location. This was a double-blinded, placebo-controlled, phase 3 randomized controlled trial. And irrespective of where the drug was used, it showed benefit. It reduced the risk of morbidity and mortality event by 40% compared with the placebo. The efficacy was consistent across all subgroups, age, gender, functional class, PAH etiology, and background PAH therapy, because it was used as monotherapy as well as combination therapy. It was very well tolerated, and this was consistent with other prostacyclin therapies. The patients in the selexipag group received it for a median duration of about 70 weeks, monotherapy or as add-on therapy, or both, compared with placebo, and demonstrated a reduction in clinical worsening with a significant p-value. In PAH and COPD patients, selexipag helps in functional improvement as well as improvement in the pulmonary vascular resistance and cardiac parameters. So what is the SOP that you should be following? If you have a patient with COPD, look for the signs and symptoms suggestive of pulmonary hypertension. Work up the patient for pulmonary hypertension. If this pulmonary hypertension, even if you have to undergo a right heart catheterization, there's no harm in doing it if there's a doubt about presence or absence of pH. If it is less than 20, that means patient has no pulmonary hypertension, and you manage the patient with COPD as such. If the MPAP is more than 20 and you think it is proportionate to the degree of lung damage, then you just leave it as such and manage the COPD. But if there is a pulmonary vascular phenotype, or if there is a coexisting PAH, in case of presence of coexisting PAH, then definitely you must try the targeted PAH therapies. If there's pulmonary vascular phenotype, you may consider using pulmonary PAH therapies. Of course, selexipag seems to be the drug of choice in the current circumstances. But if the mean pulmonary artery pressure is more than 20 and the arterial wedge pressure is more than 15, then you need to consider it to be a left heart disease and then manage the left heart disease. This is the kind of protocol that we also follow at our center, and we are proud of it. Thank you so much for listening to me this evening, and I'm happy to take any questions if you have.
Thank you, Vivek, sir. Thank you very much for your exclusive talk on selexipag, sir, for the uses in COPD. Sir, we are seeing some questions. So, with your kind permission, can we go through these questions, sir?
Yeah, sure.
Yes, sir. Our first question is: did selexipag recommended for the Eisenmenger syndrome? I think Dr. Neeraj sir will answer this question.
It's a very interesting question. We agree, Griffon study was not entirely for Eisenmenger syndrome. This included 150 patients which were having a congenital heart disease. But beautifully, it had a very significant number of Eisenmengers among them. And they have shown that 6-minute walk test and quality of life did show an improvement. So selexipag is a very good add-on therapy for Eisenmenger group of patients. That means patients with shunt lesions who have developed irreversible pulmonary artery vascular disease. In those group of patients also, selexipag can improve the quality of life. So definitely it's a good add-on therapy.
Yes, sir. Sir, the second question, I think it is from some patient. The patient is experiencing low SpO2 between 80
Yeah,
to
I
85.
have gone through this patient, and I think I've gone
Yes.
through the question.
Okay.
And the patient says that her oxygen saturation is 80 to 85 after some hours since taking Selexipab, and doctor has stopped Embrisentan when they started Selexipab. Are those two medicines clashing? I think the best person to evaluate you is your own doctor, because since he has started Selexipab, he is probably the best person who knows about the molecule, and that is why he has started it. So saturation of 80-85% for a shunt lesion. If we don't know, the most important thing for a pulmonary artery hypertension is to first get in touch with a PH specialist so that they evaluate the cause of pulmonary artery hypertension. Any case of pulmonary artery hypertension should be thoroughly investigated for the cause of pulmonary artery hypertension. And of course, the drug therapy should be titrated, and the follow-up, which we feel, we means we as a PH clinic, Dr. Nangia, us, PH clinic is not one person. PH team is a team approach. It includes a cardiologist, it includes a pulmonologist, it includes a dedicated radiologist, it includes a rheumatologist, and and of course many times a consultation is sought from the ENT and orthopedician. So all these groups together constitute a PH team, and once your team feels that yes, this patient is not any of the treatable causes and is a idiopathic variety which needs a therapy, your primary doctor is your best doctor. And I believe your doctor is doing a good job substituting a Selexipab. Maybe he felt that your side effects are causing the problem, so he review Embrisentan. He might uptrate or downtrate the therapy, but your doctor will be the best guide. And oxygenation, saturation does not guide the therapy. Saturation in no way guides the therapy. Saturation is one of the markers of, can be one of the markers for or downtration of therapy. It is your 6-minute walk test. It is your clinical improvement. It is your echo parameters which guide as to escalation or de-escalation of the therapy.
Yes, sir. Thank you, sir. Sir, the third question is in functional class 3. How many different group drugs can be given as combination therapy?
So another important, I think initial questions are probably for the first talk. So,
Yes,
but
sir.
excuse, I think I'll take this. So most of the, if you see the Griffon study, if you see most of the publication of Selexipab, many of them are case reports. They are always group 2 and 3, and they have really shown a benefit starting in this particular group of therapy. Now, how many different groups of drugs can be there? To summarize, you want to ask whether we give endothelin receptor agonist, whether we give phosphodiesterase inhibitor, or we give a prostacyclin, a group of drug, prostacyclin analog or prostacyclin. These are the three available group of drugs. The therapy is essentially directed by the baseline parameters, baseline functional class, which is not only the functional class, but baseline parameters such as 6-minute walk test, such as your echocardiography parameter. Need be, it is a good idea to start all the three pathways simultaneously. Problem, at times we find this degree of headaches and degree of pulmonary vasodilatation is much more. That means they have some hypotension and some headaches, which are much more common starting triple therapy. So many times your doctor would resort to two lines of therapy and add on the third therapy, as was done for the previous patient which asked. So because of the decreasing the side effects, they will start with two pathways and may add on the third pathway. But if the patient tolerates, starting the three therapies for a functional class 3 is a very good idea.
Thank you, sir. I think, sir, you have already answered this question during your talk. The dosage of Selexipag, it depends on the age?
For all the patients, all the studies which are published till now, starting with a 200 microgram dose and escalating up to 1600, is for patients more than 18 years of age. Now, your question is specific for patients less than 18 years of age. We are awaiting a very good randomized trial, which is currently being conducted, and 2028 it is bound to come up, which will answer this question for sure. But having said so, there are multiple case reports, which talk of therapy between 2 to 18 years of age. And many of these trials, since they are not randomized, I would quote, they are not randomized, but still the therapy is from 5 years, from 2 years to 10 years, 10 years to 18 years. It is 50 to 100, 100 to 200. In this particular range, it has been tried with very good results.
I think, sir, next question is also from.
Yeah, I've just read it. From
Yes,
somebody's asking, is a patient of idiopathic PH for last 4 years. With Selexipag improve his quality of life and span of life. Which one is more effective, oral or intravascular? I think this particular patient has done a good research. I think much more than even the doctors. And I congratulate you for patiently listening to us and having such a idea about such widespread disease and treatment modalities. Yes, there is a IV Selexipag, which is available not in the Indian market, but it is available from 2018 and the trials are being conducted. IV and oral, as of now, from the initial response, is considered to be the same efficacy. Is roughly the same efficacy. So IV over oral, I would say no. Oral is equally efficacious, but the dose varies with individual patient. Some patient might benefit with minimum dose and some might benefit with a higher dose. And this depends on the individual receptor abundance in each individual patient. Some may have a down regulation of receptors and may not benefit and may require a higher dose. Mortality benefit has been shown from Selexipag study. So whether this particular patient will benefit or not will actually be decided not by the age and the idiopathic PH. As emphasized earlier, there are a lot of parameters which needs to be seen, which include one, your baseline clinical parameters, your 6-minute walk test, any degree of exercise you are able to do, or the amount of oxygen consumption basal which you are doing, the patient is doing. Thirdly, the good echocardiographic parameters, the biomarkers such as BMP, which Dr. Nange had beautifully discussed, how the biomarkers can actually guide. So all these parameters together decide whether we add on another therapy such as Selexipag or not.
Correct, sir. Again, sir, the same question is there. Below 10 years, can it be given it as a, what is the starting dose? At what
so I think we have discussed it.
Yeah.
The starting dose for less than 10 years is in the few case series, I would say, they are not randomized control trial, again emphasize, has been 50. The 50 to begin with. It can only be always be escalated as per the response to therapy from those case reports. In fact, one of the patients had a 5-month-old child whom they had taken a consent and started therapy, but most of them have been beyond 2 years of age.
Yes, sir. The question is, if triple combination does not work satisfactorily, can fourth drug can be added? Are there drug interactions if all the used as a combination therapy?
So I think this will be my last question because this was from the first group of first talk. So
Yes,
this is a very good question. For physicians in the group, it is a very good question. What we want to do is, we want to target 3 specific pathways of therapy. Endothelin receptors, the inhibitors, prostaglandin inhibitors, and of course the prostacyclin pathway. Adding these 3 groups is very good. But if we are adding the same group of drug, is actually not a good idea. If you are adding 2 groups or 2 drugs of the same pathway, would actually only increase the side effects and would not be a good idea unless you feel that your patient is so sick that you want to sort of mix and match and you do not want to escalate one drug to the maximum doses. In most of the patients, it will be a good idea to target 3 specific pathways rather than giving 2 drugs of the same pathway. The 4th drug, one should think twice. The only exception would be inhalational iloprost. Why I say so? Because inhalational iloprost has got limited side effects because of limited systemic absorption, and add-on therapy with the inhalational with the Selexipag and the inhalational iloprost is not a bad idea. both being from the same group, it is still a very, very good idea to initiate both the things. Having said so, we must remember that ileoprost is at present not available in the country. Many of our patients are getting it because of patient support groups and from certain pathways which we have developed over the years to import this drug.
My next question to Dr. Vivek sir. How was Selexipag acceptance when it's administered to newly diagnosed IPH patients?
So the acceptance with IP in patients with IPH has been quite all right. They've not faced any major side effects because of the drug per se, and the tolerance was quite good.
Sir, the next question is, did Selipag works on ILD associated with PH or on the ILD?
So Selexipag, basically there's an entire registry that has been conducted. It's more of an observational study in the US of about 500 odd patients, which is called the sphere analysis that they've conducted. And they've actually shown that in patients who had an underlying CTD, there were about 26% of these patients were underlying CTD. 49% had idiopathic PH and 24% had some other diagnosis. In all these patients, the drug was used for a prolonged period, but what was seen was that the risk either improved, the risk of the disease basically either improved or it remained stable. It did not deteriorate with time. So that is what Selexipag is able to do. It is able to control the further deterioration and also improve in the pulmonary parameters, the vascular parameters in these patients.
Sir, the next question is COPD and severe PH, where it is more than 60 to 70 mmHg is the pulmonary pressure. So seek your comments on this, sir. What kind of usage of drugs?
Basically, if they, as long as the pH, the pulmonary artery pressures are around 35, that's kind of acceptable and it is proportionate to the damage to the lungs. But if it is disproportionately high, touching 60, 70, then it's unlikely, and the pulmonary lung functions are still preserved, then it's unlikely to be due to hypoxia or any of those other reasons that I just discussed. Then it's most likely an associated idiopathic pulmonary arterial hypertension also, which would need to be treated conventionally with one of these drugs.
Sir, sir, next question is, did PD5 inhibitors and ERAs recommended for COPD with PH?
So basically, as far as recommendation is concerned, there are no recommendations to be saying that you use because it is use any of these drugs in patients with COPD and pulmonary arterial hypertension, because there is no way of proving it that this PH is idiopathic PH is not a part of COPD. But as I said, if you feel that this is totally disproportionate, that means that the lung functions are preserved and the PA pressures are very, very high, the pulmonary artery pressures are very, very high, then yes, that is the only indication where you can consider using it. Again, we don't have very strong data to support its usage, but it sounds logical to use it. It has to be used under very controlled environment that you're able to monitor the patient's pulmonary hemodynamics from time to time and see that there's no deterioration in these patients. As I showed earlier also, that some therapies resulted in deterioration in the lung functions and hypoxia because of the VQ mismatch. So we need to be very careful with that, and it can't be just started off the shelf.
Right, sir. Next question is, what drugs from different groups are compatible as combination therapy for severe idiopathic pulmonary hypertension, where the pulmonary pressure is more than 90 to 100 mmHg, sir?
So as I showed you in my slides also, that you could combine one of the endothelial receptor antagonists like abrisentan or bosentan or macitentan with Selexipag, or you could combine a PDE5 inhibitor like sildenafil tadalafil with Selexipag, or it could be a combination of abrisentan and sildenafil, abrisentan with tadalafil. So all these combinations are possible. And in fact, it is recommended now to use a combination rather than a monotherapy in these group of patients.
I think, sir, this is the last question. Selexipag for it can be used for CTAP or any data available for group 4 PH patients.
So basically for CTEF also, there is a study from Japan where they've used Selexipag in, I think, about 78 patients who were inoperable and had persistent or recurrent pulmonary hypertension after even a pulmonary endarterectomy or a balloon pulmonary angioplasty. And they found there was a significant improvement in the pulmonary vascular resistance and other hemodynamic variables in patients with CTEF, although the exercise capacity remained unchanged with the use of Selexipag in this group of patients. So only in patients where it is inoperable or it is happening repeatedly or has not got corrected despite a surgical intervention, where you could consider using it with fairly good results.
Sir, this was the last question, sir.
Thank you, Vineet. Thank you for asking these questions. And thank you, audience, for joining in this evening. And thank you to the entire MSN team for having us on board today.
Sir, I will take just 1 more minute, sir. Just last 2 slides, sir.
Yeah, Vineet, but there's one interesting thing which has come up. We must, to conclude, there is 3 pathways which are working, and Selexipag,
Yes,
which is a 3rd pathway, we didn't have a drug for it, and now we have a drug for it. So it should be optimally utilized. The Dr. Nangia has clearly shown when the drug is a drug, it does not differentiate where it is going. It does not have a brain. So it goes through whole of the body, it goes through whole of the lungs, and vasodilates not only the body also, vasodilates the lung also. So if there is a VQ mismatch, it is likely to worsen. So always get in a good pulmonologist in, because we always know that if some lung segments are not perfused, not ventilated well, and they are perfused, they are likely to worsen the mismatch. So that is the whole business. At times, the pathways may be incomplete. There will be the number of receptors may come down. So you are starting 200 say, मुझे कोई फायदा ही नहीं हुआ है, मैंने तो start किया. No, that is not done. You might have to escalate the therapy up to 1600, because you might read for an X patient a 1600 dose, for a Y patient the 200 may work, depending on the receptor population. So I think these are the 3 just for using a Selexipag therapy as a.
Yes, sir.
And I thank you for the.
Thank you so much, Dr. Neeraj, sir, for elaborating everything very clearly, sir, and making our audience understand, sir. And at the same time, thank you so much, Dr. Vivek Nangia, sir, for clarifying all the doubts and clarifying the usage, especially for PH along with COPD patients. Sir. So last 2 slides, I will take just your permission. Sir, as already aware, we have already launched our product Selipag, which is available in 200 microgram as well as 400 microgram. The trusted partner in every stage of PH. We also have our existing therapies in PH management like Pulmonext, PH20, Pulmonext Kit, Tadovas, Mesitent 10 milligram, and Rioshiovert, sir. Sir, we may be the young player, but our drive and enthusiasm are based in associating with you. I would like to thank you so much, Dr. Neeraj, sir, and thank you so much, Dr. Vivek Nangia, sir. And at the same time, thank you so much, all the audience for your patient listening, sir. Thank you so much, sir.